Thank you so much, ma'am. Again, grateful to APSPOS and AIOC for making me part of this session. I would like to acknowledge my colleagues Aditya Goyal and Nikita who helped me put together this presentation and show what we had to see. So typically as those of us who see squints, this is part of our day job. We look for turns, we look for tilts, we look to see whether the chin is up, whether the chin is down, and that's something that we do very routinely. But when you talk of somebody walking or gait, what does it even mean? Today, most of us have specialized in ophthalmology, subspecialized. We're talking of decades of experience in the subspecialty that we forget some of the simpler things. So when you look at how gait is defined, it is defined as a method of locomotion using reciprocal placement of the lower limbs for both propulsion and support. So that makes it very important that gait is not just to get from point A to point B, but also to support a person. So this is a typical child that walked into our clinic for a review. He was wearing glasses. He was a 7-year-old who was accompanied by his mother with complaints of repetitive blinking and that he would look at the corner of his eye, and this is a kid who is just randomly jumping around. No, he had a birth weight of 3.1 kg, C-section. He had delayed speech. Mother said he was extremely careless and would trip and fall. And the child went to a regular school. He was well aware of numbers, alphabets, colors, and shapes, which was kind of okay for his age. When we recorded his visual acuity, he was wearing a glass with about a 0.5 diopter spherical, and we recorded a vision of 6.6 for distance and N6 at about 35 centimeters. Retinoscopy showed a little bit more of minus, and when we did a cyclo and then an acceptance, we saw that with -1 diopters, he was reading 6.6 and N6. When I did a cover test, unfortunately I don't have a video of this, the child showed a little bit of an esophoria with his present glasses. Slit lamp exam was perfectly okay, fundus was okay. And I had actually visited a friend's clinic where I saw this child who was walking on a tiptoes, and the minute he put yoke prisms, apologize that the image is a little blurry, the child was immediately able to plant their feet on the ground. So that kind of got me curious, saying, okay, have I really looked at how this child is walking in? And then when you look at this child when they're walking in, the length is slightly reduced, the width between them, so they seem to be kind of walking on two sides. And if you look at even the way his hips are, they're kind of flexed out. And they take a little bit of time in terms of changing their stance. So when they're moving from one step to the other, that's what we noticed was happening. We then got his binocular vision assessment done. Again, sorry, the video is not playing. But yeah, so we noticed his fixation was okay. Saccades, his saccades and pursuits showed poor ability and accuracy, and then his extraocular movements were okay. MEM showed a little bit of a plus. We were not able to do any visual perceptual skills test. We then sent him to a developmental pediatrician because one, we thought his gait was kind of a little off. We had read some literature that we thought it was, and then the child was diagnosed to be an autism spectrum disorder. So what lessons we had learned from a little bit of what I had visited my friend and what I saw in this child is that the gait is very important when the child walks in, and that kind of gives you a clue as to how their balance is, what they're doing, how they're kind of managing their environment, their overall spatial environment. That gives us a huge, huge clue. Even when we're doing a cover test, typically we tell the child to sit down, we plonk a target, and then we start the cover test. The way they slouch can even give you an idea as to whether they're myopic or hyperopic. So a typical myopic child would have a little rounded shoulders with the scapula kind of pulled in, then they would kind of bend down. And that kind of a posture you will typically see, and the tail is kind of tucked in. So you see the child with the tail tucked in with slouching, probably they're myopic. And that kind of gave us a clue again in this child with that esophoria, saying that maybe he was slightly undercorrected as a myopia. There have been some published literature. A lot of these are very, very old literature that looked at behavioral optics. A lot of these images, we found it circulating on WhatsApp, and some of it we couldn't even figure out references for this. I did try a Google image search. But again, looking at the way a person stands can give you some idea of what you would typically find in your exam. And these are things that now we've started finding very useful in terms of estimating in children who are hyperactive in terms of whether we are appropriately correcting them. Because once you see them back on review, if you see that the posture has got a little better, whether the hip is in front of their back or whether it's in front of the abdominal line, that kind of tells us whether we need to undercorrect or overcorrect them, and that enables us to further figure out what has to be done. So typically this is how that line is supposed to be. It is supposed to kind of intersect the auditory meatus, the acromion of the shoulders, the acetabulum of the pelvis bone, and the center of the axis. So that's a perfectly straight thing. So anybody who's got their head in front of this line is likely to have a reduction in accommodation. Anybody with a lead with the chin coming in front, possibly they are myopic. So what we look for cues again in these children who are myopic or hyperactive is that they have a very narrow focus. They're very focused on what they want to do or what they want to see. If they kind of are looking at your fixation step and you want to suddenly switch, it may take a little bit longer time. Again, their posture in terms of lordosis, whether they have their knees away, helps us. Uncorrected myopia does exhibit esophoria, and they have a difficulty in terms of perceiving their entire spatial context. So this again is very, very critical for us to understand that the clinic doesn't overwhelm them. The furniture that you keep, the pictures that you put on your wall, all of these could kind of overwhelm these children. They do have a weakened core musculature, and typically you would see them kind of tiptoe. So it's as though they're climbing a hill is what you would see them walk. This child then underwent vision therapy subsequently, and we were able to enhance most of his perceptual attributes. His fixation got better, saccades pursuits got better. The esophoria did continue a little bit, but the child did develop fusion, and we were able to do a perceptual assessment that showed that he was a little lagging for his age. What did we learn from this is, as pediatric ophthalmologists, the minute we see a squint, we kind of trying to break our head as to what the diagnosis is and what we should do. Should we look at prisms, glasses, surgery? So multiple thoughts come into play. We're extremely worried, saying that am I missing a vertical, am I missing something else? But it is very, very important for us to examine the child as a whole. It is very important that you start observing the child as they're walking into your clinic, because that itself can give you a lot of cue. Again, another lesson that we've learned sometimes is that diagnosing a child with autism spectrum is different from branding a child as autism spectrum. Today, there is a tendency for every hyperactive child to be called autistic. We should be very, very careful about it. And not every child with autism needs to be hyperactive either. So looking at some of these other cues of whether you see some esophoria, whether you see some postural variation, whether you see any spatial discomfort that the child is going through, can help you kind of guide them to go to a developmental pediatrician, not a routine pediatrician. Again, you have to be a little cautious there. Again, these are some lessons that we learned even with this child. He was seeing a regular pediatrician. We're not picked up the fact that he had a spectrum illness. And again, as ophthalmologists, we are very kicked about the visual acuity chart. We want all our patients, if we operate cataract, to read 6/6. If we have given glasses, we want them to be 6/6 and 6. But I think we need to remember the very old adage that the eye leads the body, and the vision goes much beyond that into movements, gait, posture, and behavior. And what we have seen working with children with spectrum is that vision therapy and training does to a very large extent improve behavior. We may not have clear answers in terms of the actual method with which it helps, but it does definitely help. Once again, thank you so much for having me as a part of this session.
Thank you. Are there any questions or comments from the floor?
Can I?
Yes?
So I'm an oculoplastic surgeon, but I can probably claim myself to be a strabismologist. I induce a lot of strabismus, doing orbital decompressions, doing fracture work and all this stuff. The quick questions and comments about each one of them. Dr. Surendran highlighted the role of presbyopia and allied healthcare workers. And he rightly pointed out, as the surgeons evolve from 20s to 30s to 40s to 50s, there's a barrier to have presbyopic correction. One of the tips he taught me was, when I was going through the phase, just accept it and wear your glasses. And I think there's a natural barrier for us all to do that. And I, as an oculoplastic surgeon, I'm doing punctal dilatation. That was my first tip off that I'm not there anymore. So thank you for the pearl. The second question was for you, actually. She talked about rupturing a muscle. And every single time I give a child for enucleation to my resident or my fellow, I dread that muscle rupturing, the way they're yanking the eye. So I was wondering, the Pitt syndrome, how much of it is a surgeon factor on top of the other factors that you talked about.
Yeah, and that's why I highlighted the fact that, she actually was the primary surgeon and I was the assistant. So obviously, if she was my assistant, that's what I would have blamed, saying maybe she yanked it too much. So in my case, I was the assistant. And I don't think I'll take the blame after doing so many surgeries.
But when you put the muscle back after the pits, we know that the function is not the same.
Yes, that's
For example, when I do fracture dissection, inferior oblique disinsertion for a combined flow medial wall fracture, sometimes I consciously disinsert the inferior oblique. But a novice will actually not disinsert from the periosteum, but actually transects the inferior oblique. And we know when you put it back, the torsional diplopia is almost impossible to manage. And the patients go through a lot. So the logic behind just reattaching the muscles.
Yeah, I think reattaching the muscles will have a lesser such impact than actually, getting through the muscle belly, because that's where the function of the muscle is. The strength of the muscle is in the belly. Disinserting at the tendon, that's what we all do with squint surgeries. I don't think that has, that's not, we are using the impact in a favorable way to, relieve the patient of what the problem they have. But PITS it breaks in the belly of the muscle, and I think even if you sew it up together, it's never going to work the same.
But that's what you recommend, right?
That's what the literature, the survey results are, that 45% patients had resuturing of the muscle. They could have resutured. If that was the question, were you able to resuture the muscle, they might have answered yes. But what happens after that, is for the next set of strabismologists in the department to put a paper out.